Okay, let's talk about esophageal cancer. Esophageal cancer, 5-year survival rate is less than 20%. The reason is esophageal cancer because of the very strong um, lymph system through the esophagus and gastro GI tract is it's by the time it's found, the patient usually has metastases. The other problem is there's not a lot you can do for esophageal cancer. Um, think of this tube that you eat with. If you've got esophageal cancer in it, you've got to get the cancer out. When you take the cancer out, now you've lost your mechanism of eating. You know, you just can't take out a piece of the esophagus, sew it together, and think it's going to work the same. It does not. So the other high risk factor that I mentioned is patients that have Barrett's syndrome, which is a long time of GERD. You develop Barrett's. Barrett's has a high risk of esophageal cancer after that. So usually your first sign is all of a sudden you have a hard time swallowing. And it's usually very at the beginning with me. All of a sudden I can't swallow meat. Meat gets stuck. Then I have to eat my meat, chew it well. Then it's soft foods. All of a sudden potatoes, mashed potatoes get stuck. Then liquids get stuck. Well, about that time, over a long period of time, the patient finally goes to the doctor. What they find out is the cancer's been growing bigger and bigger, causing problems with the food going down through the esophagus. If they had gone to the doctor the first time, larger amounts of food would stick, they might have been able to catch it earlier. But people just think, oh, I'm eating too fast. I need to chew my food better. That's usually what happens, and they ignore it. So poor prognosis usually metastasized. Usually it's the first sign is that globus sensation in your throat or dysphagia. That's the problem. And basically they're going to do an endoscopy, upper GI, do a biopsy. Treatment is basically radiation, chemo, and surgery. They can take out the piece and put in the Dacron graft, but it usually does not work as well as it sounds. So the patient has to have esophageal gastrostomy, so a feeding tube in their stomach, or esophagoenterostomy. So the big issue is nutrition. The patients just do not get enough nutrition. They lose a lot of weight. The cancer metastasizes. It's a horrific death. So the big ethical decision is, do I die from the cancer or do I put in a feeding tube and try to prolong life? Acquiring enough nutrition, then it becomes a quality of life. I've seen patients who have esophageal cancer. Yes, they have lived 1, 2 years, 3 years with it, but they can get down to 70, 80 pounds because they just don't have enough nutrition because of the complications and because of the metastases. So it's a quality of life. I've seen other patients, they say, I've got this, I got a poor prognosis, just keep me comfortable, and the patient dies relatively few weeks to months. Hiatal hernia. Hiatal hernia, you have, most common is a sliding hiatal hernia. The other one is a rolling hernia. So what happens is the stomach is moving up through the diaphragm, causes a lot of pain. It can cause GERD. Patients have horrific pain when the stomach slides up. So they feel like they're having a heart attack. So signs and symptoms, looks like heart attack, feels like GERD, heartburn, gallbladder problems. So they need to change their lifestyle. If they want to have the surgery to have this stopping the stomach from rolling, then Nissen, the Nissen fundoplication is the answer. So that's the treatment for hiatal hernia. Gastritis, you just have an inflamed stomach, sorry. So let's find out what's causing the gastritis and stop. Could be medication, could be an ulcer, could be Helicobacter pylori bacteria. Could be smoking can cause that, burns, stress, food, alcohol, steroids, breakdown of tissue. Could be anything. Could be a high HCl. A lot of patients make too much hydrochloric acid, and that irritates the pepsin, causes a breakdown of the stomach lining. Signs and symptoms: you don't feel like eating, nausea and vomiting, you have epigastric tender. The bad thing about gastritis is it can lead to an ulcer, so you don't want to risk for bleeding. If the hydrochloric acid is eating into your stomach lining, if it eats into an artery, then you will have a major bleed. So let's stop what's causing it, put the patient on some medication to help relieve the gastritis, like proton pump inhibitors, put them on Carafate, something to line the stomach to get them through. Peptic ulcer disease, erosion by the GI mucosa, by the HCl and the pepsin. Duodenal ulcers are more common than gastric ulcers. Usually have a high acid content. A lot of patients that have peptic ulcers, it's caused by H. pylori. They can figure that out by doing an endoscopy or blood work. Give the patient the right antibiotic, it'll clear up and kill H. pylori. Patient has lots of gas pain, lots of cramping. The big issue is perforation and hemorrhaging. That's the big issue. Another problem is if it's in the wrong spot, it could cause obstruction, so you don't have gastric emptying. Treatment: upper GI, let's rest, go on a bland diet, or at least anything that's not going to irritate that ulcer. Stop smoking, maybe stop drinking alcohol as well. That will aggravate it. Drug therapy, antibiotics, antibiotics for H. pylori and acids, H2 receptors, proton pump inhibitors. If it's really bad, the patient may need to be MPO, put them on an NG suction, fluid replacement if they've been vomiting, surgery if that's needed for the ulcer. So if somebody has a gastric ulcer, duodenal ulcer, there's two surgeries. One of them is called the gastroduodenoscopy or a gastrojejunostomy, or Billroth 1 and 2. Two different procedures. One takes more of the stomach out than the other ones. These are two major surgeries, but common for gastric duodenal ulcers. Appendicitis. We all know what appendicitis is. Inflammation of the appendix. Hopefully get it under control or have surgery before it ruptures. Right lower quadrant. McBurney's point is located halfway between the umbilicus and the right iliac crest. Amazingly, someone can have a lot of pain from appendicitis. All of a sudden it feels like it went away, and the patient says, "Oh, I'm better now." It might be because it ruptured. Once it ruptures, the pain will probably reduce, but that's then the high risk of getting peritoneal infection, peritonitis, or becoming septic. Intestinal obstruction, adhesions, could be a tumor, could be a volvulus where it turns on itself, could be an occlusion, could be intussusception, could be strangulated. All these can cause an obstruction in the small bowel. Anyone that has a small bowel obstruction, they immediately know something's wrong because of pain. Fluid and gas builds up in the stomach and gut, and then they start vomiting. Classic signs: if you have a small bowel obstruction, you have nausea and vomiting. Could be from anything. Some of those will resolve. They don't have to have surgery, but some will not. So in the small intestine, small bowel obstruction, it comes on very rapidly, very quickly. Vomiting is usually always present. Pain is present. They may have a bowel movement for anything that's post-obstruction, and their abdomen gets very distended. It happens very quickly. So usually these patients, they're fine 1 minute, and all of a sudden it comes right on. It may resolve or it may not. If it doesn't, they need to have surgery. So they're going to have lots of pain, vomiting. It could be fecal smell, could be projectile vomiting. Bowel sounds could be absent or active, depending where you're listening, on which part of the quadrant. Remember, your small bowel is zigzagging through your gut, so where are you listening, before or after an obstruction? Lots of gas, fluid buildup, distension. These patients need to have an NG tube placed, do an x-ray. Dangerous is a barium swallow because that could cause a perforation. Usually x-ray or a MRI, CAT scan might be able to detect what's going on. Usually what happens if you have an obstruction, you will see fluid before the obstruction and lots of gas pockets after the obstruction because there's nothing can get through. So that's a very common sign on x-ray. If you have a large bowel obstruction, it's completely opposite. So you have onset is very gradual. Vomiting is rare because you're way down into your large intestine. You're 20, 30 feet away, so vomiting isn't happening. Pain's going to be more of a low-grade cramping abdominal pain. You may have a bowel movement. It may be diarrhea what's happening, or you may be absolute constipated and can't do anything. You're not moving anything. So it could be, it depends where it's happening in the large intestine. So for all these patients, we need to have NPO status, especially if it's low. If it's a small bowel, let's put an NG tube in. Let's watch for breakdown on the NG tube, around the nares, dryness in the mouth. If they're breathing through their mouth, they're going to need swabs in their mouth. Going to need IVs for fluid. We don't want them to become dehydrated. So let's do surgery if it doesn't resolve, or monitor that. Probably use a Foley catheter just to make sure their I's and O's are what they need to be, even though they're getting IV fluids.